Before we begin our program, I would like to highlight a few housekeeping items. Today's program will include a lecture followed by a question and answer session. During the presentation, all participants' lines will be muted. However, you may submit questions to the presenters at any time by typing them through the chat feature located to the lower right corner of your screen. Questions will be answered at the end of the program in order to allow the presenters ample time to cover the material. Following the program, each registered participant will be emailed a link to the recording of today's call. As a reminder, today's call is being recorded on Tuesday, August 23rd, 2016. Welcome to the Preventing Hospital Readmissions VNAA Blueprint for Excellence module tour, presented by Visiting Nurse Associations of America. I'd now like to turn the presentation over to Liza, who will facilitate today's call. Liza?
Great. Thank you very much, and welcome, everyone. It's a pleasure to be here. This is Liza Greenberg. I'm a senior consultant with VNAA, and I will give us a quick walkthrough of what we'll be doing today. First, I'll introduce the speakers. We have with us Kathy Peirce, who's Executive Director and Chief Nursing Officer of the VNAA of Care New England. She's a registered nurse with experience in home health, hospice, and acute care, and has worked for multiple home health care and hospice organizations. She has a nursing degree and a Master of Science in Management. And I'm Liza Greenberg. As I mentioned, I'm a senior consultant with VNAA, and I work with membership organizations on quality and performance improvement initiatives. And it's been my pleasure to work with a wide array of VNAA members, including many on this call, to develop modules for the VNAA Blueprint for Excellence. So today's call, we're focusing on a new module that we've just launched on the VNAA Blueprint for Excellence that focuses on preventing readmissions. And based on the number of people on this call, I can say that this is an area that you already know is important for home health and hospice organizations, and there's many reasons why there's been an increased focus on it over the past few years. Obviously, as home health and hospice organizations, you all are very concerned about providing high-quality patient care and improving the patient experience. But in addition, there's a number of metrics and financial incentives that are sort of being layered on to your organizations. So we've got readmissions measures that are in Home Health Compare. It's a factor in star ratings. The IMPACT Act will ratchet up that emphasis on preventing readmissions by looking both at discharge to the community, how long the patient stayed in the community, and readmissions. Payers want it when they're issuing contracts through value-based purchasing or through their ACO programs, and it's a factor in reimbursement. So clearly it's a very important issue for all of us. I do want to acknowledge that this module was developed with the extensive input of the VNAA Quality Council. We convened a readmissions working group that worked through the material you'll see today and helped us to figure out what to highlight and prioritize. And Kathy Peirce, who we'll be hearing from shortly, was a member of that working group and shared with us a number of her experiences helping to prevent readmissions in her organization, and we asked her to sort of give the view from the field before we walk through resources that are available on the VNAA website. So many of you may be familiar with the VNAA Blueprint for Excellence. It's been around, I think, about 3 or 4 years, and it's got a very extensive array of material to support your work in home health and hospice and to improve quality practices. Each of our modules is developed by a best practice work group, which provides insights, helps to steer us to the right material, highlights evidence that we should focus on, and other information that we need to bring you a concise and consolidated module of information. We try to rely on evidence-based practices as much as we possibly can, but there are some areas where evidence isn't available, and that's where we rely on expert recommendations and the best practices put forward by our members. And particularly in preventing readmissions, it's always a work in progress. Information continues to evolve, new evidence gets published, and so the blueprint evolves over time as knowledge continues to develop. Each of our modules has many different options, and it's really kind of a menu of things that you can choose to help improve activities within your organization. There's no one right way to do many of these quality improvement activities, so we present a menu of things that have worked in other organizations and something you can then analyze to see if that works in an organization of your size or with your patient population, other factors. And we expect that this is not the only tool you use. Obviously, you're using pathways that are developed internally, accreditation, your own data and management systems, compliance activities. So this is another layer of quality that you can add to your organization. And as I said, it's customized so that you can pick the options that will work within your organization. So sort of returning to the question at hand about the readmission problem, you know, nationwide we know that about 20% of patients discharged from inpatient settings are readmitted. That varies by region. It also varies by discharge diagnoses, but the top causes are people with CHF, septicemia, pneumonia, COPD, and cardiac dysrhythmias. But again, it sort of also depends, as you all know, on the level of support in the home, socioeconomic status, and other factors that can be risk flags that help us to identify which patients we can focus on to help reduce that readmission number. And on the other side of the spectrum, hospitals are also having those incentives. So this is an opportunity for partnerships around preventing readmissions because the hospitals are also being measured and penalized where there are readmission problems. So, knowing that there's no magic bullets, we asked Kathy to talk with us a little bit about the menu of options that she's working on within her organization. So you can take a look at what one organization is doing, and then we'll walk through our internet resource site so that you can spend more time looking at various strategies that might work in your own organization. So Kathy, can I turn it over to you?
Certainly. Good afternoon, everyone. Kathy Peirce, I'm from the VNAA of Care New England, and I think Liza said it so well when she said there is no magic bullet. We were trying a number of initiatives and always considering adding or changing our resources to do other things to figure out what is working. But right now, we really have 4 sets of initiatives or approaches to focus on hospitalization and preventing rehospitalization. Next slide. So the first one is with our care transition nurses. So we have nurses that are actually in our system hospitals that will evaluate patients that are leaving to go home. They don't see every single one coming to home care, but anyone who appears to be high risk. They'll also see them in some of the nursing facilities that we work with a lot, so the nursing homes. They'll identify concerns. They'll share those with our intake clinicians, as well as put a document in our electronic medical record to prepare the clinician that's going out there for any concerns that they may need them to look at. They'll also do some preparation with the patient and their family for the realities of home health. A lot of families don't understand home health at all, and I said it facetiously, but really no one is coming to live with them. We're really just going out there to support them a couple of times a week, 3 times a week, really usually not more than that, but depends on their need. And sometimes families believe that somebody will be coming in every day or staying with the patient for long periods of time, and that's going to make the difference. And in some cases, home is not the best option for people. So that's always a big concern area, and our care transition nurses do a great job of kind of forewarning us. We do have some patients sometimes that will go home on a trial, if you will. We had a 90-year-old and 91-year-old brother and sister hospitalized at the same time, believe it or not, and went home because they really, really wanted to go home. But everyone said, we don't think this is a good idea, and they were supported by their nephews who said, you know, let's try it. And they were home 24 hours, and they realized this was not working. And so then it is the challenge to get them into some kind of a facility. It is easier to do that from the hospital level, but sometimes we hit that. So our care transition nurses do give us a heads up. That's probably our first initiative. Next slide. So, and then we have the call would, you know, come into our intake department or the fax or the email, you know, depending on how we get that referral. And our intake clinicians call the patient or their family the day or night before. We find that really helps because we can make sure they're going to be home. We can find out if they're going to have their medications, or are they already home, and do they have their medications? Did they get their prescriptions? What kind of questions do they have? What kind of concerns are out there? Do they know to put their pets away when we come out? All the basic things, but it also helps them to take the visit that day. So when we call the next day, and say we're going to come out probably 9 o'clock or 10 o'clock, they're more ready and they're more willing to take the visit. So we find it's twofold. We found a lot of our admissions were turning us away the day we were coming out there, and this has helped us. We also will have the admitting clinician, we have an admission team. So they really are truly experts in the admission process, and I know there's pros and cons to having an admission team. Some of the pros are that they're really good at doing the admission. Some of the cons is that they form this relationship with the patient and family, and then they're not back in that case again. So we always go back and forth with what's the best thing. But right now we have an admission team. It seems to work very well. They will front load the visits per best practice to figure out what this patient needs, particularly for those that are high risk. And as we know, most of our patients coming out of acute care facilities are more likely to be readmitted because they're frail and they've just come out of the hospital. We also we have an ACO within our system, so we work with them to let them know we're admitting patients that are actually shared patients. If the patient may be part of the ACO, it may not be part of complex care management, which is the level in which they're utilizing a fair amount of resources and they're following them more one-on-one. So we'll work with them. Sometimes we'll recommend they put the patient on complex care management. Other times we'll just take the admission and see how it goes. We look at our patients' needs when we're out there. Telemonitoring is a great tool to use that we can kind of monitor patients on a daily basis without being in the home. So sometimes that's appropriate for patients. Lots of our patients really benefit from our fall risk program, so we will enroll them in that if it's appropriate. We'll look at pulmonary rehab program if that's appropriate for them. We have a program we do at home. And on everyone, we do a very thorough medication reconciliation and a lot of education on that. We're also trying at that initial visit to understand what their advanced directives are. That's been a agency initiative, and we've really been trying to ramp that up recently so that we understand. We have a couple of community hospitals in our system, and particularly one of them tends to have very old. Our patients are very old, and they've lived a pretty good life, but now they have a lot of chronic comorbidities, and they're easily in their 80s and sometimes 90s. And so sometimes code status has been discussed, and a lot of times it's never been discussed with them prior to coming home. So that's somewhat problematic, so we do go through that. Next slide. Our next level is we use SHP. Some people have Home Health Gold. Ours is SHP, and we will scrub our OASIS data to see the patients that come up as high risk for rehospitalization. And we do this on a weekly basis. We usually do it once a week, pull all the patients, and then we have our nurse practitioner do case conferencing with our staff on, usually it's Thursdays and Fridays. That's kind of a schedule that's worked for us. So they get like a 10-minute slot, and of which they call in. We ask them to write an advanced illness SBAR about that patient within that medical record prior to that time. And then the discussion is really related to what's this patient's advanced illness, what kind of symptom management is going on, is there a change in their level of function, have they had recent weight loss. And then from that, we'll try to understand what led to their initial hospitalization, and is there really a plan to minimize the risk of them going back in. We will discuss advanced care planning. And some of the questions we really, present to staff is, if this patient was alive in a year, would you be surprised? Really trying to help them focus in on, do we think we're near the end of life here, or where are we at? We'll do follow-up discussion based on the patient's acuity. And then sometimes the patient is referred within the agency, either to our palliative care team, could be to our hospice program. They could receive additional services through our nurse practitioner home visit program. And sometimes they're really appropriate for an emergency response system, the button, I've fallen and I can't get up, that kind of a thing. So it's really trying to look at the patient holistically, make sure we're addressing their goals, their desires, and their needs, not so much what is important to us. So we've found this program to be very helpful. And on a weekly basis, we probably discuss about 50 patients. And, if I pull up last week, we had 2 patients. We recommended that they get the emergency response system. We had one that we wanted a palliative evaluation on. We had one we needed a hospice evaluation from. And we had one that was admitted directly to our hospice team. So, you know, about 2, 3, 4, 5 patients, about 10% may move from the general home health focus into an area that makes more sense for them and has a better focus for them. The patient may not move this week, but they may come up for discussion again in another couple of weeks or a month, depending on what's going on. So that's some case conferencing that we're doing. It's pretty intensive, but we find it's very helpful. Next slide. And then what we do every week is we have a standing meeting with all of the clinical managers, and we do a rehospitalization review of all patients that went into the hospital that week. So we actually have a tool that we use. We track the patients to see where they are, and then the tool really includes the patient's name, who's the case manager, what team are they on, and then who's the reviewer. And then we look through and we gather demographics as the patient's age, were they part of our ACO, who do they live with, what's their code status, and then what's their admission diagnosis, and then what was their readmission diagnosis. And then we look at the number of days they were on service and what evaluations they might have been waiting on that were pending. So if they had nursing, admit them, but we're still waiting on PT and OT, how many days has it been? So what we try to do with these things is trend and look at our, do we have any trends? So do we look, did our visits match our orders? How many visits did we have with different clinicians? So like if you had a nursing order, but you had 5 different nurses in 2 weeks, you know, so we're looking at all our potential weak areas. We look to make sure we did an OASIS transfer that, you know, showed that they went in the hospital. We'll look at their med list to see what on there is concerning. Did they have a doctor's appointment? Were they readmitted with the same diagnosis? You know, did we document our MD communication in the record? And did we have any coordination of care meetings prior? And then we kind of form an impression, like, was this hospitalization avoidable or unavoidable? And so it's eye-opening to see what comes out of those. And case by case, you can get mired in the detail. But when you start to pull back from it and look at it, we start to look at, okay, who's going in week 1? What's the percentage going back week 1, week 2, week 3, week 4? Where do we fit in comparison to every other agency? What things could we be doing better? Did we miss opportunities? I find, you know, probably be ideal to bring the clinical staff in, but we struggle because we need them in the field. But I did participate, I don't know if it was 2 weeks ago, in a VNAA presentation that Christiana Care did, and they do bring staff in, and I really started thinking that maybe something that we want to do, because it's such a learning process. And what I find is the managers, no one's defensive. We all just sit there and say, what opportunities did we miss? Could we have done something else? So it's a learning opportunity moving forward to make sure we implement these things quicker. But we are doing it after the patient's hospitalized, and I kind of like the idea of doing it before they go in. So it may be something we try to adapt to. But for now, what we continue to do is review them all, and then really look at, you know, what opportunities did we have and which things did we miss. So that's the process we're currently using at the VNAA, and I'm happy to answer any questions that people might have.
Great. Thank you so much, Kathy. We're going to move right to our blueprint tour, and then we'll have questions. People are going to have questions about either your menu of options that you've selected to try to reduce readmissions or any of the resources we present. So we're switching gears now, and we're going to look at the new module being launched on the VNAA Blueprint for Excellence. And most of you are probably familiar with the blueprint. Some may not be. So we'll start at the very beginning. You should be able to see our main website right now, which is called vnaablueprint.org. And this is kind of your launching pad. So although we'll click around to many different resources, if you get lost and you want to come back and find some specific piece of information, this is probably where you'll start on our main page. Then usually the place I suggest we go is right to this how to use this website link. And when we click on that, we get to the index that has all of our modules containing information for home health and for hospice. So the Preventing Readmission section is here in the home health area. And you can see we have a number of other modules. These are linked throughout the pages we'll see today, but should you ever want to get back to look into more detail, for example, on front-loading a visit or strategies for improving your rates on flu and pneumonia, you can come back to this main page. Earlier this year, we did launch the 5-Star Best Practices module, which focuses in on activities directly related to the star ratings measures on the CMS website. So those of you who are members have access to that, and it has a lot of really great information on improving your outcomes in the 5-star ratings. So we'll go here to Preventing Readmissions. This is our new area now. And every page within the VNAA blueprint is organized similarly. So on the top we have tools and critical interventions, references and resources, training and measurement. There's an overview page. And the reason that I point these out is that you probably won't absorb all of this information today, but this is a very valuable resource that you can use with your own staff or your colleagues to come back and take a look at it and use this almost as a training session. So I'll show you at the end where there's a PowerPoint presentation that you can download that provides this in an overview, but also just sort of looking at different pages and discussing it within your organization can really be a helpful quality improvement strategy. So in this case, I'm going to start with our measurement and evaluation page because, as I've said, one of the key drivers behind this drive to reduce readmissions is measurement and evaluation issues. So all of the blueprint pages are linked to other places where you can find information. So if you're new in the beginning with your organization, or you just want to be able to understand things in more detail, you can use these hot links to find. So for example, this one here that I'm pointing on would take you right to the Home Health Compare website. This one would take you to the Medicare star ratings. And as I pointed out, one of the reasons why a lot of organizations are looking at readmissions is these two very important Impact Act measures. These aren't currently linked because the measures are still in draft, but VNAA is tracking development of the Impact Act measures very closely, and Danielle Parati will be putting out information on the measures as they're released. I guess one thing that I also wanted to mention before leaving this page is the patient experience piece that, you know, as it becomes a more important measure and a factor in your all's quality improvement strategies, understanding how patient experience is related to preventing readmissions, I think is an important component, and it's helpful to look at various resources. And at the bottom of every page we have more resources. There's another page that duplicates many of these. We tried to make it easy for you to find information regardless of sort of where you're coming in from. So you'll see sometimes we have the same item linked multiple times. That's hopefully just to make it easy for you. So going back to our main page, I think I'll go next to really where the meat of most of our Blueprint for Excellence pages are, the tools and interventions. So our work group on preventing readmissions wrestled with a lot of issues and how do we prevent readmissions, what are people doing, and then we ended up sorting them into these categories that you see reflected in the blue bar. So sort of the big groupings of interventions that home health organizations are tackling are around putting processes in place to track patients, patient needs and outcomes. So that's kind of what Kathy Peirce was doing around having both a data tracking system and then routine meetings in place. Collaborating with partners to improve the continuum, and I'm going to drill down into each of these in a moment, but it's things like partnering with your hospitals to have better early warning systems, or developing continuum of care, transition of care type handoffs, developing protocols for certain illnesses. Those are the kinds of things that you could do with partners. Better understanding patients' risk factors, so knowing the patients really well and using that to scale up the care plan when you need to. Engaging patients, and that's sort of using the best practices that we know of to help them participate actively in their care. And then two of the areas are the ones that have been shown by evidence to really underlie quite a number of the readmissions, which is managing medications more effectively and addressing functional status. Those are two issues that are increasingly associated with being readmitted. So let's look at some of the specific recommendations. So again, as I said, we can't really go through each of these today, but we wanted to point out to you what's here so that at some point you can come back and take a look and see what works for your organization. So developing a structured approach to preventing readmissions. Again, it's sort of using the data you have in hand to look at it in a very systematic way and to develop systematic interventions. So using pathways, making sure that you use the best practices in communication, such as SBAR communications, scaling up is something I've already mentioned, working very closely with rehab to make sure that you're addressing functional status. And again, it would be something you would build into your EMR or build into your checklist so that you would make sure that you've at least done the assessment and understood the patient's needs thoroughly for every single patient. And then understanding where your opportunities for improvement are around readmission. So looking at who went back to the hospital, what you could have done differently to keep that patient out. Again, that's one of the ideas that Care New England has evolved. And I should highlight that embedded within our organization here on the blueprint, you'll see from time to time case examples. And some of these were created just for this module, and some of them are also incorporated in other modules within the blueprint. But these are fairly detailed descriptions of what certain members of VNAA or your colleagues are doing around quality improvement activities. So this one is Porchlight, which is a 5-star organization, and what they did really to use their data to maximize the information they had on hand to drive quality. So you'll find case examples sprinkled throughout these pages. Another area that came up from our work group was the idea of developing transition of care protocols. So having very specific processes for when does the physician get called, when do you refer to an advanced practice nurse, what are your protocols for day of discharge contacts, what are the things we do at an initiation visit for someone who's very frail. So it's probably something you would tailor to your own organization, but that kind of protocol can be very helpful to make sure that something doesn't fall through the gaps or a frail patient doesn't get a same-day visit and ends up getting readmitted. And then systematic processes to make sure that you engage the patient. So this is this last item right here. So doing a check-in call, reviewing the plan of care on a regular basis so that if the patient's health status is changing, the plan of care is changing. Using care pathways and protocol that aligns with the payer's protocols, or it could be the hospital's protocols, but you don't want to have two separate programs for telehealth, for example, or for some other kind of clinical intervention that the payer might be doing something different, and also have a case manager in the home, which ends up being confusing for the patient and not a good use of resources. And then help the patient understand who's doing what in the home and how that's going to help them stay healthy or get better. So the way you open and shut these blue bars is through these little plus-minus toggle things here up in the corner. And we're going to go now to collaboration to look at some of the things that our work group recommended. You know, this is something that I'm sure has always been on your radar screen, but developing relationships with physician practices is really critical around the issue of readmissions to really get them to respond in a timely manner, to address the issue of medications being missing or wrong or potentially even having negative interactions. So having effective strategies for communicating with physician practices is really another part of the key. And again, their incentives are changing as they have new measures under MACRA, or the hospitals have measures under various Medicare requirements. So everyone within the system is getting these same kind of prods to reduce readmissions, and hopefully that means that there will be an increased willingness to communicate with home health about strategies for reducing readmissions. Again, there's the issue of partnerships and how do you develop programs. We know of some VNAA members have partnered with the emergency department so that they get flagged if a patient's going in, so that they can then kind of crank up the interventions with the patient. Again, often it relies on knowing who's at risk, knowing who is touching the ED or getting admitted, and then developing collaborative programs to try to get the patient what they need to keep them out the next time. And another important piece of it is another aspect that Kathy touched on, which is helping to improve the end-of-life continuum. We all know that patients in home health can be very frail. Many of them are approaching the end of life, and many of them haven't really consciously thought about what they want their advanced care plan to be or their end-of-life plan to be. So there's a lot of emphasis now on helping to engage patients in conversations about the end of life and what their demands or wants are around that, and helping to meet their needs through palliative care where necessary. And just for your information, we also have a new module that's launching on improving the end-of-life continuum of care. And Thursday we have a webinar to walk through that. But if you look in that index that I showed you at the beginning, you'll be able to find our new module about improving the continuum of care of end-of-life. And it's something to think about within your own organization, how palliative care and end-of-life planning can help reduce readmissions. They are kind of interrelated. Understanding risk factors is another key area, and so everyone obviously is doing risk assessment as part of their OASIS, but really thinking through what do the risks mean to the type of care that we can offer, scaling up the care, potentially front-loading. We did want to point out that the evidence is actually not always as strong as we'd like it to be on certain things that we're doing a lot of in home health. So both front-loading and telehealth, they're not 100% evidence-based, but there is certainly a lot of belief that they're effective. So it's something to keep an eye on as you develop programs like that, which can be costly, to see whether it's really having the effect that you want it to have. Because if it's not delivering any return in terms of keeping people out of the hospital or keeping them healthier, then it may not be the right strategy for your organization. Again, using pathways, using your data, those are all the kinds of things that you'd want to be doing around addressing patients' needs based on their actual risk level. Engaging patients, again, this is something that many of you already focus on quite a bit. Patient education has been a routine part of home health forever, but there are some new ways around helping make sure that the patient understands that it's you they should call rather than going to the emergency room. Helping the patient feel listened to by having them set the goals of the meeting or set the agenda for what they want from home health. These are the kinds of things that can really help engage the patient and help your care become more patient-centered. And when you have that, you have a more trusting relationship that can kind of indirectly help to drive reductions in readmissions and more use of home health at a lower intensity level, which is what you're looking for. The last two areas in our readmissions module are around very specific clinical areas, and you know, as I said earlier, a lot of what drives readmissions is ineffective medications, interactions between medications, missing medications, things like that. So really developing an extremely systematic approach to medication management is an important strategy. This is also an Impact Act measure as well. So looking at your system for medication reconciliation, making sure that your system is very seamless so that if you find a discrepancy or an issue, you're able to follow up on it and get a resolution in a timely way. So the bullet points here are things that you know, are part of a strategy. Again, there's no perfect solution for MedRec, but it is such an important issue that we continue to wrestle with it. And I think that there's new information too around the role of caregivers in medication and showing that it's not just the patient, it's also the whole caregiver array, the ones who live in the home, the ones who come in and out. All of the caregivers have a role in medication usually, and some of the gaps in care can emerge from the fact that there are so many caregivers involved in the home health care setting. And then simplification is getting to be another major area of emphasis where, let me get rid of this, where people recognize that patients are on so many medications, it really dramatically increases their risk of interactions, and many organizations, many of VNAA's members are looking at how do you involve a geriatric pharmacist or even the physician, to try to reduce the overall number of meds, and that can be better for the patient in many different ways. And then functional status is the last area where, again, there's more evidence showing that changes in functional status are often an underlying factor in readmissions, and so much of the work you're already doing around assessing functional status and improving functional status really also relates to your work reducing readmission. So preventing falls is a critical function, making sure that patients can handle their ADLs safely, and that any deterioration gets identified and addressed relatively quickly before the patient might end up back in the emergency room. And a couple of these areas are also addressed in our 5-star best practices module and in our hip and knee joint replacement module. So there's a lot of overlapping information in the VNAA modules. And I just wanted to point out as the last thing on this page that we have a number of tools. These are pulled from our member organizations, members who develop creative or at least comprehensive approaches towards doing certain types of assessments. We have a number of them arrayed here on the page that they've given us permission to have them here, and you're welcome to download them and adapt them or use them in a way that's most helpful to your organization. So let's go back to our main page, and we'll look at two last areas of resources that are available to you. We'll go to references and resources, and as I did say, we do have evidence behind our recommendations, although not everything is 100% evidence-based. But you'll find on this page, if you're interested in looking into what are the evidence on certain things, we organized some of the best articles in terms of we just basically formatted the abstracts and put them on this page. But these are the ones that really drive a lot of the information that's under this website, and helps us understand what interventions are most evidence-based. You'll also find here other resources that can help you. Again, if you're using this as a quality improvement tool within your own organization, you might just use VNAA's page to help you get to other resources. So looking at what the Agency of Healthcare Research and Quality says are some strategies, CMS's guide to preventing readmissions. There's a lot of information out there. And sorting through and figuring out what works for your organization is one of the things that will be a follow-up from this activity. And not all of the information is for home health. Some of it is hospital related, and you might need to kind of cull out what makes sense for your organization. So that's the resources and reference page. And then last, I wanted to just show you our training page. And we have both training that's available from VNAA and training that might be from other sources. So the Home Health Quality Institute, the HHQI, has a course that's specifically for home health on the fundamentals of reducing acute care hospitalization. It's an evidence-based intervention that I think it was funded by CMS, but it's free with registration. The Institute for Healthcare Improvement has done a lot of work around readmissions, and they have a toolkit to help you more effectively communicate across different types of practitioners, their SBAR toolkit. One of VNAA's members, the Illinois Home Healthcare and Hospice Council, has developed a course on palliative care, which helps, again, improve that continuum of care around the end of life. So these are things that you might use like at a lunch and learn type of session within your own organization. And everything we just saw in the walkthrough of the website is actually in these training slides here for the blueprint. So if you wanted to download this and use it within your own organization, it has all of the information on the website, but downloadable format. So again, you can use it with organizations when you're offline. And so that's the basic walkthrough. Let's see, go back to this home page here. If you're looking for the slides that summarize this website, they're also here at the bottom of the main page on reducing readmissions. And that kind of summarizes the information. I did see a chat question come in about the slides we were using earlier from Kathy Peirce's presentation, and the answer to that is yes. Heather will be sending out a link to the slides and to the recording of the webinar. And so with that, I think you've gotten the full tour of the Preventing Hospital Readmissions. We're going to open it up now for questions. And Heather, can you let us know if anyone had a chat question and unmute the phone lines?
Yeah, we did have somebody come through with a question for Kathy. She was wondering how many patients you have for the hospitalization review.
Every week is different, but this week we have 17, so we're just freaking out about how come we have so many this week. Typical, it seems to be about 7 or 8 we're reviewing that went into the hospital that week. And our census, just so people have an idea, we're about 1,000 home health patients.
And Kathy, have you seen any changes in your readmission rate since you began a more comprehensive approach?
No, we've seen it move just ever so slightly. It's not going up. We look at our referrals, at least 90% of our patients are coming from acute care facilities, maybe even higher than that. So we know we have a very at-risk population. And some of the things that we have improved is we do education with them with stoplights and those kind of things about symptom management. And we've done a lot of education about, we call it the call me first. So call us before you call 911 or the emergency. But in a lot of situations, by the time they call us, we are advising them to call 911. So it's good that we've gotten through to them. They are calling us with their issues, but in many cases, we're already at the point we can't help them. So it's a little discouraging at times, but you know, our other trends that we're seeing is week 1 is really heavy-duty return to the hospital. So we're really trying to look at why is that happening? Were they not ready to come out? Were they not educated properly? Was home just not a good setup for them? As it seems to be pretty, probably about 50% of our patients that go back in week 1.
Mm-hmm.
We've had a few other questions. If anyone does have any questions, please feel free to go ahead and use the chat feature on the GoToMeeting screen. One question was, who in your agency does the pulmonary rehab?
It's a combination program with we have a respiratory therapist, which is a little unusual in home health. She's part-time and does work with our therapist, so PT, OT, nursing, work with patients in pulmonary rehab. So our respiratory therapist would go out and do some basic education and make sure they're appropriate for the program, and then we lead them through, and we have a certain standard by which their participation would be in the program. We don't have a huge number of patients that go through that every year, but we have a number who graduate and really do better at home, so we feel it's really worthwhile.
Great, thank you. There is one person wanting to know if you're able to share the tool that you use to evaluate your rehospitalization.
You mean like the checklist? I'm guessing that's what they mean. Sure, it's not a big deal. I could email it. It's really just a list of questions we ask ourselves, and then we try to trend them into a database at the end, but I can certainly email the form to anyone who's interested in using it.
Great, thanks. Are most of the hospitalization patients Medicare only versus dual eligibles, i.e. Medicare and Medicare Advantage?
Rhode Island is very heavy on Medicare Advantage. So we, on average, run about 40% of our patients are Medicare. But we have probably, you know, tons of Medicare Advantage as well, and we're very heavy commercial. So most of our patients are Medicare Advantage that are going back in, but we have a number that are Medicare as well, and they would be in our ACO. So if we're talking patients over 65, we're pretty heavy. Dual eligible as far as whether they're Medicaid or not, it's a mix. We have one area of the state that's a little bit heavier, but it's not our main issue.
And Kathy, you really listed a lot of things that you were trying out to see if they would work. Have there been elements of your readmissions program that you tried out and you found didn't work for you, or things that you tweaked in terms of your process to improve your initiative?
You know, I think one of the things we've done is try to question when patients call us and say, I don't feel good today, I don't want you to come out. Like, we don't just let that go to a scheduler and go away. We get a clinician on the phone. So usually it's a manager to talk with them to find out what's going on and to really say to them, this is a day you absolutely need our visit because that's why we're there, because you don't feel well. So I kind of get it when they don't want a therapist to come out. They don't want to go through the rigors of therapy if they're not feeling well, but we absolutely want a nurse to go out if someone's not feeling well. So trying to get patients to take those visits and making sure we bring it to someone else's attention. We've also implemented some wellness calls. It's very hard with resources, but we've tried to mix in that we actually do some wellness calls periodically on patients to see how they're doing or what their needs might be, especially if they had a doctor's appointment, so we're not seeing them, but we kind of want to check in. So that's one of the things that we've implemented. There's not too much that we've taken away, but as I did say, I really was intrigued by Christiana Kerr's talk about reviewing with the staff the patients. They do it at medium and high risk, and I feel like since we do our high risk with our nurse practitioner, could we expand it and do our medium risk and kind of expand some of our learnings to our direct care staff? It's hard because they're crazy busy in the field, so we'd have to, figure out a way that they could call in versus having to drive to the office. But it's definitely something that piqued my interest the other day when I listened to that call.
Okay. And I was intrigued when you said that a lot of times once you get a nurse practitioner involved and the patient does call, it's too late. They're going back to the hospital if you have a call me first type of initiative. Why are they going back in those cases, and are there any situations where a nurse practitioner visit could help them?
Well, it's not the nurse practitioner cases that they're going back in necessarily. It's just that if the patient is due for a visit that day and they call us and say they don't want one because they're not feeling well, we're trying to figure out why. So the way we use our nurse practitioners is they may be an adjunct to the home health clinicians that are going out, or when the patient's no longer qualified for home care services, so they no longer have a skill or they're no longer homebound, that might be a good time to have our nurse practitioner home program step in. And so they may only see the patient once a month, but they call them periodically, they keep tabs on them, they find out what's going on with them. For example, one visit our nurse practitioner went out to, and she said to the patient, oh, I noticed your leg is really weeping. Oh yeah, I don't know what that is. And she looked at it and said, oh, you have a cellulitis. So she immediately prescribed her an antibiotic, got it to her, and she never had to be hospitalized, but she was admitted back onto home health services at that point in time, and so we saved that hospitalization, but we're able to keep her home. So, utilizing, we only have 2 nurse practitioners, and one is involved a lot administratively, so really in the field it's like 1.5. So there's a number of patients they kind of manage together would be maybe about 90 to 100 patients. So it's a fair number. They're not seeing them that often, but trying to manage them along, and we feel like it's very much a worthwhile program. They're just able to do different things at their visit that the nurses in home health can't do.
Mm-hmm. Great, that's helpful. Are there other questions from the people on the call today?
We had one other question. Do you utilize the HHQI hospitalization reports for your agency?
I don't know if we're actually using that particular report. We of course measure our star rating and look at all our other areas, but we're really running our own reports, and we actually have an administrative person calling and checking our facilities to make sure our patients are not in. So we get alerted pretty quickly if they're going in, which sometimes you don't even know till you go in to make the next visit because no one's contacted you. So we try to keep on top of that. We try to get the med list immediately to the facility if they go in so that they at least have the latest and greatest from that. So we find many of our patients are being readmitted with the symptom of shortness of breath. So it's kind of interesting. It's not like that was their initial diagnosis, but it seems to be a reason why they're going back. And we've also seen some blip in urinary tract infections. But we can't really find one particular trend that this is the magic bullet, as we would say. This is why everyone's going back in. It just seems to be a little more UTIs and a little more shortness of breath than we might have expected.
Are you thinking of creating any interventions around either of those two clinical issues?
We have done some intervention with our staff about just basic hygiene teaching, more to our female patients than our male, about the UTIs and the avoidance of UTIs, and really trying to, our hospital systems are really trying not to use catheters or to take them out very quickly. So some of those nursing protocols to take them out has helped our numbers go down as well. But really trying to be on top of that. So that's one initiative we have for that. For the shortness of breath, it's kind of hard because it doesn't seem like it's really, it could be for numerous different reasons. So they have heart failure, but they weren't hospitalized for heart failure, but they come out and 2 days later they become short of breath, go back to the emergency room, and it's due to heart failure, but it really wasn't their initial. So we're trying to focus on all of their diagnosis. But for many of our patients, which is probably true for all home care agencies, they have multiple comorbidities, and they are truly the frail elderly. So one domino falls and many follow.
That's an important concept. I think that's the end of the questions, unless there's any final questions from the audience.
We did have one other question. One participant was wondering if you could explain how the nurse practitioner program is funded.
It's a great question, actually. The nurse practitioner program is somewhat of a loss leader, if you will. So they can bill for visits, but the productivity that you would need would have to be amazing to be able to cover the salaries. So they bill for visits when they go out, and then the other way, we really feel like we're giving better care to our patients and to the population. So somewhat it serves our ACO and system initiative, and then moving patients to the right place for care, whether it be moving a home health patient to hospice when that's appropriate, or even patients. Some patients are just admitted to the nurse practitioner home visit program. They're not really admitted to home health. So when they need home health, then they move them in. So they're somewhat of a referral source as well. It is expensive, but we're really getting to the core of what are patients, what are their advanced directives, what do they need, what's the best symptom management for them, how do we treat them the best way and keep them where they want to be. And we feel like we're able to do that. We wish we could expand that program, but financially we are limited to what we currently have. But it is key. And we do use our nurse practitioners also to do some face-to-face for our hospice patients as well. So we, not that that's billable, but it's absolutely a needed service we would have to pay someone else to do, that would have to be employed from the hospice regulation perspective. So that's how we manage it.
That's helpful, and I've heard a lot of organizations are looking into how to create nurse practitioner programs, and then obviously are also wrestling with the financing piece.
It's a tough one. I mean, but the professionalism, the expertise, the knowledge of medications, I mean, some of those pieces you just can't hold a candle to having a nurse practitioner. And so we feel like it's really worth it.
Thank you, Kathy.
You're welcome.
Last invitation for questions. Well, we thank you all for being on the call with us. Heather will make closing remarks, and I know she'll be sending out links to the slides and presentation. So Heather, do you want to close it up?
Sure. Thanks, Liza. I'd like to take this time to thank you all for joining us during today's webinar. I'd also like to thank our presenters, Liza and Kathy, for sharing their expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you all have a wonderful afternoon.